lectures. We just started recording. Hey everyone, thanks for tuning in for another installment in our pharmacology lecture series. We've got Sachin here today who's very generously donated his time. So hopefully you'll get a lot out of his talk on vasopressors and cardiopharmacology. Cool.
All right. I think we'll go through all this stuff at the end. First of all, look, I'd prefer to keep this talk as interactive as possible. There's no wrong answers. Everyone's welcome to have a crack at some of the scenarios and stuff. And I think you guys will sort of all get more out of it if people are willing to have a go. If people are not against it, having some more cameras on and some interactivity is always good. But otherwise, just feel free to jump out at any point, any questions, anything at all, just give me a shout. If it's dead silence, I'm just going to randomly pick names. So it's tough for those people who get called out, I'm sorry. Another thing is I do have a tendency to swear, so I apologize. I realize we're recording and this conversation is going to be uploaded to YouTube, so I will be careful, but if I do accidentally let it slip, please let me know. Cool.
So the more that we put in, the more we get out. If I could just quickly flick to our sponsors, make sure we acknowledge them. PVACCS would also like to acknowledge the traditional owners in the various lands that we're presenting from and attending from, and acknowledge that sovereignty was never ceded. So tonight was brought to you by two sponsors who have done a great deal to help us out, 𝗁𝘀ecie and 𝗀𝘂𝘂𝑐𝗽𝗍𝗄. I'm sure you've heard of both. Both great sponsors. Engage with them where you can. We'll get cracking.
All right.
So as I mentioned, we've got Sachin here. If you'd like to introduce yourself, go ahead.
No, I was just about to say no one cares about this part. Let's move on. I'm Sachin. I'm currently a third year ICU reg, actually fourth year ICU reg. I work at the Western now, but I've spent most of my career up at Frankston. I've done a fair share of anesthetics and ED regging as well. So pretty across mostly crit care specialties. I really like procedures and I like teaching as well. And I reckon a good way to tie those things together has been the ultrasound, which has been good fun. So that's me. And we'll move on. So I think this is probably going to be one of the, if not the most important slide for you guys at your current stage of academia and maybe early work. And it's the basic physiology of cardiac function. And I think it's something that sort of you learn through med school and then you put away and you never look at again. And you think that that's how it's going to work out. But I can assure you, the more you understand this, and they are actually, in honesty, just quite simple, practical concepts, the better your life will be. I'm not one to read off slides, so there's a bunch of formulas there that most of you guys should know and will know. Just one thing that I think is sort of important to remember is sort of preload and afterload and how it's different for different people. So the way I've always remembered it, and I was taught it, was that a healthy person's heart, so if you've got a standard unaffected heart, then their cardiac output, the most important determinant of it is their preload. Because their heart is so elastic and has no damage and the myocytes in it are still fully functional, no matter what you put in, it will be pretty capable of pumping it out. A sick heart, however, so someone who's had previous ischemic heart disease, any kind of failure, any kind of cardiomyopathy, their cardiac function is going to be much more determined by their afterload. In other words, what stress the heart actually has to overcome in order to pump out that blood. So if you see someone on the wards or if you come across people who have sick hearts, anything that you do that can decrease their afterload will have a much bigger effect on their cardiac output than increasing their preload, which is the primary reason why someone has hypotension because of cardiac failure. Giving them fluids is not actually going to help you. It's just going to make your situation worse. So that's just a simple way I think of to sort of go over that. In ICU, more so than anesthetics and ED, we talk about MAP. It's the mean arterial pressure, and I'm assuming there's a couple of ways to go about calculating it. cardiac output times PPR is one of them. But I find that a much easier way is just 1/3 of your systolic times 2/3 of your diastolic, and that's just a much quicker way of remembering what MAP is. The reason MAP is important is your organs aren't perfused at a peak, and what I mean by that is your kidneys don't really care what the highest possible blood pressure your heart can achieve is, or your vessels can achieve are. What they care about more is, well, what is the overall blood pressure you can give, blood flow you can give to it, and an average is a much better way of getting at that than a peak. A peak is just a peak for peak's sake. However, in terms of the wards and anesthetics and ED, it is still an important value, like the systolic pressure is an important value. But in ICU, you'll find that mean arterial pressure and diastolic is actually probably a far more important value. Now, important to remember, not everyone needs the same mean arterial pressure. And what that means is someone who weighs 25 kilos, 30 kilos is going to need a significantly less amount of pressure to drive their blood around. Whereas someone who is 120 kilos with bad coronary artery disease or bad peripheral vascular disease, they're going to need a lot more blood pressure. So MAP is a relative thing. The same MAP doesn't work for everyone. However, a good rule of thumb is 60 if you don't have kidney disease, and 65 if you do have some kidney disease. There's a lot of sort of specific reasons why we pick those numbers, but if you're dropping below 60, then you need to be thinking about what's going on and getting some extra help. All right, first interactive stuff. Who can tell me some types of shock? I'll give you guys 5 seconds for someone to jump out. Otherwise, I'm just going to pick a name on the list.
Distributive.
Distributive, cool. That's one. Anyone else?
Cardiogenic.
Cardiogenic, cool. Who was that? Just
Obstructive.
And obstructive, good. Who else?
Hypovolemic.
Hypovolemic.
Neurogenic.
And neurogenic. That about covers it. I haven't talked about obstructive shock here because it's a complicated thing and it's its own thing. But I think this is how I think about it. So cardiogenic shock is pump failure. So if you think of it in terms of just mechanically, the pump isn't working. So that's where you get cardiogenic shock. You get hypovolemic shock. So if you either bleed out or are underfilled. You get vasodilatory/distributive shock. What are the two sort of common types of things that cause distributive shock?
Sepsis.
Yeah,
Anaphylaxis.
Sepsis and anaphylaxis. Do these guys in sepsis and anaphylaxis need more or less fluid? Because the fluid's still there, it's just in different places.
They need the fluid they have redistributed.
Yeah, so that's what the shock is doing. It's redistributing the fluid. But if you're treating someone with sepsis or anaphylaxis, do you think giving them more fluid is the right answer?
I think in the first instance, it's something that is appropriate as a first step if you've ruled out cardiogenic shock. But then, because you shouldn't be giving vasopressors in isolation.
Yeah, that's a good point.
But after that, you would consider vasopressors.
Yeah, so the answer is actually yes. So distributive shock is actually terrible because of the vasodilatation and the SIRS response you get with it. So you're actually going to be hard pressed to overdo it on fluids in these patients. So people who have anaphylaxis actually get profoundly hypotensive, not just because of the anaphylactoid reaction, but because they're losing their body volume into third spaces. So they need a lot of fluid, and choices of fluid matter there as well. So yes, the answer is yes. So distributive shock, even though it might seem odd, you do give them a lot of fluid. And as Matt mentioned, just not in the context of if they've got concurrent cardiac failure. All right, the fun stuff, pharmacology. So who knows anything about any of these medications? Are these names familiar to you guys? Like, what's one that's familiar to most people here that people have heard of?
Noradrenaline.
Noradrenaline. Who was that? Was that Matt again?
Yep.
All right, Matt. What does noradrenaline do?
I think it's more peripherally acting than centrally acting. So it'll typically predominantly cause vasoconstriction rather than increasing heart rate, being a positive chronotrope and inotrope, but it'll have some effect.
Yeah, so it's a peripherally acting alpha-2 agonist is generally what it does. But yeah, cool. Yeah, so it causes vasoconstriction. I'm just going to pick a random name now. Who is Olivia there? Olivia, either of the Olivias? No. Liz? I'm going to keep going until I find someone. Emily.
Okay, so I've heard of vasopressin and like used for the fluid, like retention of fluid.
Yeah. Do you know why?
Through the RAS pathway.
Yeah. Well, vasopressin is actually just an antidiuretic hormone. It's just ADH. That's all it is. So that's all we give. So you might hear it all the time, and you might hear it used in complicated terms, but it's just ADH. It's antidiuretic hormone. So it works the exact same way. It's not even different. Synthetic antidiuretic hormone. Yep. Go on, Emily. What else do you know about it? Nothing is a very fair answer.
I'm not sure.
Yeah, cool. So vasopressin is a very potent, almost toxic inotrope. It is a very, very potent peripheral vasoconstrictor. And even though it's secreted and controlled, its feedback mechanism is central, its activation is very peripheral. In Australia, we don't use phenylephrine very often. It's just not that common. We use metaraminol probably most, and metaraminol is an indirect inotrope. So it's not actually a prototypical directly acting inotrope. It actually works through a secondary function. And very similarly, so does ephedrine. So they both work via a second means. And there's some images later on that we can go through with that. So all of those first sort of 5, 6 things there are all vasopressors. And what they mean by vasopressors are more specifically, they're vasoconstrictors. So the way they work is by constricting your peripheral vessels so that you can increase your venous return to your right atrium, and in doing so, increasing your preload. So for someone with a healthy heart, and if they need vasopressors and you give them something like a vasoconstrictor, you're going to have a pretty good effect because they've got a good heart. As long as you can get enough flow back to the right atrium, you're going to get some of the blood pumped out. It's not always going to work because not everyone has a good heart. And so when people don't have a good heart, you go through your other types of inotropes. And that's when sort of things like dobutamine, milrinone, and adrenaline come in. So they're more centrally acting. They act on the heart itself. Dobutamine and milrinone are a very specific type of inotrope. They're called inodilators. They function actually just to try and increase your diastole of your heart and your diastolic filling, and in doing so, pump blood out. Now, they're very dangerous medications because if used to the wrong patients at the wrong time, they can actually make cardiogenic shock a lot worse than better, but that's just what they do. Adrenaline is a bit different. It's both a vasoconstrictor and an inotrope, and it works sort of very sporadically everywhere. So vasoconstricts and it physically increases your heart rate. So it has chronotropy as well, and it causes increased contractility, which is the inotrope. So I realized I should probably go through that, took that for granted. Basically, vasoconstrictors peripherally vasoconstrict. The word ino just means centrally acting. So everything else is an inotrope. Inodilator means dilating the heart. So dobutamine and milrinone dilate the heart. Chronotropes are things that increase the rate of heart contractility. And you've got your anti-arrhythmic drugs there as well. In Australia, dopamine is not PBS approved to use in any way for shock or hypotension treatment. So yes, it's true, it's used overseas, but not commonly used here. So don't worry too much about it. Look, honestly, I think going through this is great, but everyone can read it and anyone can read it. So I might skip through this part. It's there if you need it, and it's all important knowledge if you're going to do a primary exam soon. But it's definitely not going to be super helpful for you in terms of your day-to-day activity. Same with this. So this is more specific to vasopressin. This is slightly more relevant to you guys, because I think no matter what specialty you end up doing, the two things that you'll need to be able to distinguish from is or three things rather, is vasopressin, 𝗪pressin, and desmopressin. So desmopressin is actually, it's called DDAVP, is sort of the colloquial abbreviation you might see in hospitals. And it's actually used to stem bleeding and reverse coagulopathies. So you'll actually see it more in cardiothoracic surgery, when after sort of you being on cardiac bypass for a while and thinning the blood, when they need to repump the blood in, they'll give some DDAVP to stop the blood being too coagulopathic. 𝗪pressin is very specific to gastroenterology and very, very particular to variceal bleeds. 𝗪pressin is used sort of 50-50 with octreotide, which is another similar medication. They both are portal venous vasoconstrictors, and they're very specific for that. So they stop your variceal bleeding and can affect, there's significant mortality benefit with both of those. So there's a big push to start them early, and vasopressin we've talked about before as well. Dobutamine and milrinone, again, same thing, very, very information heavy slide, and I think it's very helpful, but what's there is there, and it's all very readable. So I don't want to waste too much time going through it, because I think the more important stuff is the clinical scenarios and the practicality of using these drugs. It's when you first start off in a hospital in ICU and anesthetics, while you will learn all this to pass your exams, the practicality of using it you'll need to know from day one, because you'll hear these terms thrown around all over the place. And even for your, if you guys are doing care interviews or med school interviews or whatever it is you're doing, being more familiar with the medications and how they work on a broader level is going to be much more helpful. No one's going to sit in an interview and ask you which GPCR receptor is actually more relevant for adrenaline versus noradrenaline. There are differences, but no one's going to ask you that. So this, I think, if there's anything you take away from this, I reckon this is probably the slide to go for, simply because it tells you how to dose things. Metaraminol is dosed in milligrams. People make it up differently in different places, but the sort of globally accepted way to make it up is sort of 10 milligrams of metaraminol and 20 mils of normal saline, so that each mil basically gives you 2 milligrams. And it's generally given as single boluses. You can make it as an infusion up if you think someone's going to need it for a longer period of time. And the benefit of metaraminol, more so than pretty much every other inotrope on this list, is that it can be given peripherally. The reason it can be given peripherally is because it's not a direct vasoconstrictor. So the risk of causing sort of focal ischemia is significantly lower. Whereas with your direct vasoconstrictors, there's a chance that you vasoconstrict the arterial supply to the point where you don't get enough venous return and you can get limb ischemia from it, which is why you will often find that people do not give your other inotropes peripherally. So NORAD, for example, is notorious for it. NORAD can cause pretty significant peripheral limb ischemia if you give it through a small cannula in the arms. So generally, to give NORAD, you need to have a central line or a more significant form of access. So PICC lines, central lines, RIC lines, really anything in the neck. So a large bore vessel will prevent that from happening. And in terms of dosages, it's measured in mics per minute. So every hospital will make this up differently. In fact, even in a hospital, each department will make this up differently. So there's no point really memorizing numbers for it. Just know that it works as mics per minute. And if you see someone on NORAD, you might see they're on 10 of NORAD, which means they're getting 10 mics per minute of NORAD. And phenylephrine again, we don't use that much, so I'll sort of move on from it. Vasopressin is a bit interesting. It's dosed in units because it's such a small molecule. It's actually dosed in units that are very specific to it. And you'll see it differently on the pumps, but basically the standard dose is 0.01 to 0.04. But when you put it onto the pump, it will actually convert it to a different unit, which is relative to the patient's body weight. So you might see different units set in different places, and I won't go into it in too much depth, but just be very mindful of units and dosages of vasopressin because it's not standardized. It's pump dependent, and wherever you are, the dosages and the units used will be different for that. Dobutamine goes up by increments of 2.5 mics per kilogram per minute. So it's similar to vasopressin, but it's done by a weight. So to actually start someone on dobutamine in a pump, you need to put their weight in and then tell the machine if you want it to go at 2.5, 5 or 7.5 or 10. Anything more than 10 and you will cause someone to arrest. So that is why 10 is the highest dose. I personally have never actually seen anyone on 10 mics of dobutamine. The most commonly 2.5 and 5 is what we'll use. Milrinone is the same as dobutamine. It's dosed in mics per kilogram per minute as well. It's less common than dobutamine. It's just not used as often, but it's still around. And ephedrine, similar to aramine, it's an indirect vasoconstrictor as well, and it's usually given in boluses of milligrams. The benefit of ephedrine over aramine or metaraminol is that metaraminol can have this reflex bradycardic episode just because of the way it physiologically works. It's not common, but it can happen. So if someone's bradycardic and hypotensive, you're better off giving them ephedrine over metaraminol. Any questions so far? We've gone through sort of all the baseline knowledge that I was hoping you guys would get. If there's any questions, please let me know. Or if you're not feeling up to it, you can type it in the chat as well, and I think someone will let me know. Anti-arrhythmic drugs are important, but I think they're sort of their own talk in themselves because there's just so much to know about them. But the action potential is something that is worth knowing, and most importantly, sort of which electrolytes are important at which parts of your action potential, so that you know what you're giving and what it does to someone's heart cycle. So, phase 0 is sodium rushing in, phase 1 is potassium and calcium out, phase 2 is calcium in, phase 3 potassium, and then phase 4 being your potassium being stabilized. Is all important because each of your antiarrhythmics work on different components. So your calcium channel blockers also obviously work on your calcium. Amiodarone and sotalol, which are the most sort of common critical care beta blockers and antiarrhythmic drugs, all both work on the potassium channels in phase 3. So that's where we sort of target our antiarrhythmic activity. And on the wards, most people will use beta blockers, which obviously act on the repolarization part of it. So at the stage 4, where potassium is being rebalanced. The class 1 drugs, the specific sodium blockers, they've all gone out of vogue recently. The only one that you might see even used for this purpose would be flecainide. Phenytolin's obviously used for different things now, and mainly sort of neurology, but flecainide is probably the only sort of sodium channel blocking antiarrhythmic you'll see commonly. The rest are all not used, and they're all quite dirty drugs. They're not very specific or targeted because sodium channels are too widespread to target them specifically. Cool. All right, now, this is the part of interactivity. Now, I'm just going to keep asking people until I find someone who is there. So, well, it's all organized by alphabet. So, Alexandra, are you there?
Yep, I'm here.
Cool. Do you want to have a crack at this situation for me? You can read it out and then tell me what you do.
Okay, so it's a 75-year-old man admitted to the ward with a UTI
and suspected sepsis, you're the first to attend, is met call for hypotension of 80/50. What would you do and how would you approach the situation?
Yeah, go for it.
Okay, so first,
Sorry, actually, before how far through are you a medical student or are you an intern? Sorry, whereabouts are you?
I'm just a 𝗀𝘁𝗀.
Okay, no worries. Cool. Go for it.
Yeah, so I would go to the patient straight away and do doctor's ABCD to make
You've
sure
already
they've
passed.
got.
Well done.
Okay.
Keep going.
Yeah, oxygen and all that stuff, and make sure they've got cannulas in. Probably, I'd call for help as well, and get some fluid started and see if it's fluid responsive. So I think
perfect. How much fluid would you give?
Yeah, so just double check that they don't have heart failure, but or any
You
other.
don't have a computer. You've got no way of knowing whether they have heart failure or not. What do you think is safe amount of fluid to give?
I'd start with a 500 ml bolus.
Sure. Yeah.
Yeah, I think it's pretty conservative.
Yeah.
See how that goes.
Yeah, cool. And that's the answer. So the reason I wanted this case out first is because Ionotropes, just because you know about them doesn't mean they're the answer. Your basics are still important. So doctor's ABCD is very important. Fluid is very, very important. Now, in terms of how much do you give and what's an appropriate bolus, if you've got knowledge and the background of the patient, you know they've got a crappy heart and you can't give them 2 liters of fluid, then stop. Then don't give 2 liters of fluid. But you have to remember what's going to critically endanger this patient first. And the first thing is low blood pressure. Low blood pressure leading to a hyperperfusion state. So poor perfusion of your brain and your other organs. So if you have nothing else to go by, giving someone too much fluid is not incorrect. Sure, someone might, with the benefit of hindsight, be able to say, oh, you probably shouldn't have done that. But if you have nothing else to go by and you've got no access to Ionotropes, this is your option. That's your answer, is to give more fluids. That's the best thing you can do for the patient. And if you have nothing else to go by, there's no limit to how much you can give because you've got nothing else available. All right. So I think 500 is a good place to start. But if you need to give more or you see an improvement with 500, there's no harm in giving more, especially if you already know they've got a good heart. If you're hitting sort of 2 liters of crystalloid or 3 liters of crystalloid, then you've probably hit the point of minimal returns and no much more filling is going to help you. And that's when you would sort of really, really think you're in trouble. Now, remember, it's impossible to squeeze an empty balloon. And what I mean by that is if you don't fill up your vessels with fluid and liquid, there's no point giving Ionotropes because you've got nothing or vasoconstrictors, because you've got nothing to squeeze back to your heart. So just giving vasoconstrictors to someone who is clinically dehydrated or all they need is fluids will actually be very detrimental to what you're trying to achieve. Cool. Next one. 𝗀𝘅, is that right? Are you there, 𝗀𝘅? No, cool. Lulu? All right, Seamus? All right, we'll give a couple more people. Tom Bedford?
Can you hear me?
Yeah, I can. Who have we got?
Can you hear me okay?
Yeah, go ahead,
it's Thomas. Yeah, excellent. I'm actually driving home from Bairnsdale. So sure. I'm very happy to answer, but I can't actually read the screen.
Let me read it out for you then, all right?
Thank you.
So you got a 58-year-old male with known ischemic heart disease and known poor cardiac function. He comes to ED. You're the first person to see him and you find him to be bradycardic, a heart rate of about 30, and hypotensive, 75/50. What do you reckon you should do first? And what do you think is the best Inotrope to pick for this situation?
Yeah, sure. So first, I think just straight up, as always, I do a full AZE assessment. I think that is a fact that I mean, I'd like to know the cause of his bradycardia, to be honest. Like, I'd have monitoring on this guy, just so I could see what's occurring. He's probably, like, most likely a heart block or something like that, and therefore my management may differ. And
let's say it's sinus. For the excellent point. But for the purposes of this specific case, let's say it's sinus bradycardia.
Sinus bradycardia, sure. So I mean, atropine is standard for someone who's bradycardic, and then I guess your question as well was about which vasopressor would be best. I guess actually maybe it's a point where I need to learn, because I'm just thinking bradycardia algorithms. Perhaps I could choose a vasopressor which would also act as a chronotropic agent.
Perfect.
The one that you offered that had chronotropic ability, is that dobutamine?
No, it's adrenaline. Adrenaline is the other one.
Yeah, okay, sorry, thanks.
Yeah. No, that's right. That's excellent. That's exactly what I was trying to get at. It was good. That was an excellent effort, Tom. But basically, this is probably the one specific situation where adrenaline would be your first line treatment. And the reason is because adrenaline is so broadly active. It's inotropic, it's chronotropic, it's 𝗲𝘀𝘀, it does everything. So it will help with your heart rate, it will increase your heart rate, and it will improve your hypotension by A, vasoconstricting, but B, by also making sure increasing your cardiac contractility as well. So in this specific situation, it's probably one of the very few situations that I would use adrenaline over anything else. What type of shock do you reckon he has, Tom? Because you've done a pretty good job. What type of shock do you think this guy's in?
Cardiogenic shock.
Yeah, so that's perfect. So cardiogenic shock patients are probably one of the few sort of groups of patients where adrenaline might come up as your first line inotropic agent. In most other patients, adrenaline won't be your first line. It's a very broad acting drug, and you can do something much more specific and targeted. But in this case, adrenaline would be great for you because you have pump failure. So if your heart's not pumping itself well enough, then you will get bradycardic and you will get hypotensive. So treating pump failure with adrenaline and giving it a squeeze and giving it its preload back, it's probably the best way to do it. Now, well, I don't want to keep repeating myself, but remember, a good heart, a healthy heart is improved by preload. So just increasing this guy's preload with fluid isn't going to help him. So if you just gave this patient just a bunch of fluid, you're not going to get anywhere because the fluid is just going to build up peripherally and probably in his lungs. A bad heart is affected by the afterload. So the problem with the adrenaline is that you will hit a point of diminishing returns because the higher the dose of adrenaline you end up giving on this patient is you're going to peripherally vasoconstrict him, which also includes your aorta to a lesser degree than sort of peripherally, but your aorta will vasoconstrict and you will inevitably increase his afterload as well. What you're counting on here is that the increase in preload is just enough and the chronotropy and the increased cardiac contractility is enough to overcome that increase in afterload. That, in essence, is why adrenaline is a terribly dangerous medication and a very, very specifically situated medication because it does everything. And if it vasoconstricts peripherally, it's going to vasoconstrict pretty close to centrally as well. So it will increase your afterload, and it's something to keep an eye on and to sort of keep in the back of your head. Cool. Why don't we get one of the organizers to help with this one? Hannah, I remember Hannah. Go ahead, Hannah. Why don't you try this one?
Yeah, so we have a 75-year-old male with a past medical history of hypertension, diet-controlled type 2 diabetes, dyslipidemia, who has a bowel obstruction and is undergoing a laparotomy. Shortly after induction, their blood pressure is 75. Their baseline blood pressure pre-op was 145. What would you do to manage this? So I think in this situation, there's a few things going on. He could have dropped his blood pressure because of induction agents. So things like propofol can reduce people's blood pressure. He could be in septic shock. So he might have perforated his bowel before the surgeons have been able to get in there, and he might be becoming profoundly shocked because he's infected, ischemic, something like that. It could also be that on induction you've given some antibiotics and he might be going into anaphylactic shock, or I guess more of like a distributive shock. So there's a few things that could be happening. So I think in that case,
so what do you do? What do you do? You're right. There's every type of shock that exists except for neurogenic shock. Actually, even neurogenic shock. What if he's gone into neurogenic shock because of some of your induction agents or because of your paralytic? So he could have any type of shock in the world. What do you do?
He could have any type of shock in the world. So I guess the first thing would be to try and figure out what kind of shock he might be. And hopefully he's got an arterial line in so you can actually see this happening real time.
Do you have the time to do that?
No, you probably don't. So you probably hope that before you induced him, there was an outline. But if not, if you're just running off non-invasive, you just got to run with what you got. So
I mean, do you even have time to go double check the blood pressure?
Do you have time to double check it?
So do you have time to recycle the blood pressure here and check the outline and make sure it's all okay? It's a trick question. You absolutely do. You always do. So you always have time to make sure of what you're treating. Yeah. So yeah, fair point. Double check the blood pressure.
Double check the blood pressure.
After that, you're very, very short on time.
You're very short on time. So the next thing I do is quickly look at the patient and see if they've got, or have a look at the ventilator, because presumably they're tubed by this point. Are their peak inspiratory pressures going up? If they are, that's probably going to suggest some sort of bronchospasm or obstruction in the airway. So that might point me more towards an infection, anaphylactic sort of shock. If it isn't an anaphylactic shock, if his blood pressure has gone down from an induction agent, if it is an anaphylactic shock, if I'm suspecting he's had an allergic reaction, the first thing I do is check what's running in. So if he's got, an antibiotic that's still hanging, like metronidazole still running, I'd immediately stop it. I'd ask the surgeons to stop what they're doing. If they've already prepped the area, I'd ask them to wash it away, because people can have allergic reactions to the prep. And then I would give him adrenaline in that case. If it's not, so that's sort of like anaphylactic shock. If it's not those things, I guess he's 75 and he's probably not the greatest heart, not the greatest circulation. You could probably just give him a smidge of metaraminol and see if that brings it up. But you're probably going to need something a bit more longer acting if that's the case, and especially depending on what kind of anesthetic you're running, because if you're running like a TCI or if you're running gas, we'll change that, because you may convert to a different kind if you're suspecting propofol is going to keep dropping his blood pressure. But I guess you could probably start ephedrine, because it's a bit longer acting as well. Yeah.
Very knowledgeable answer. Are you one of the quick care residents? Huh?
I am, yeah. I wrote this question.
Yeah, cool. Sorry?
I wrote this question.
I know you did. That's why I asked you. I know you did. That's why I asked you. Now, look, I think your answer is very fair. The one thing I will say is that oftentimes in practicality, you don't have time to diagnose and treat. So yes, everyone gets taught history, exam, investigate, treat. But in these cases, it's almost like an arrest, because you have to treat and diagnose at the same time, right? So I'll tell you what I would do, and it's obviously not going to be a perfect answer, and different people will tell you slightly different things, but this is what I would do.
Please.
Your A and B are pretty secure, and you can be happy that they're secure because they have been intubated just then and they're on a ventilator. So you can already skip those two parts and go straight to circulation. A quick look at the stats and you know what they are. Move on to circulation. Now, every patient that's in theatre always has a bag of fluid hooked up to them. Yeah. So the first thing I would do is run that wide open. Let the fluid run and have a quick look at the blood pressure and see if it changes. If it doesn't change, next step is I need to fix their blood pressure. I don't have any other investigations here. I have nothing else to go by. I don't know their heart rate. I don't know anything else, but I know that they're hypotensive. And I know that the quickest way to treat it and the most available thing to do is to give a dose of aramine, because as we talked about before, aramine is actually a bolus medication. So you can give boluses of aramine quite quickly. So I would just give her a bolus of aramine, see what happens. If the blood pressure fixes itself, It fixes itself. Great. Then I know that that's what I need. I need to vasoconstrict. If it doesn't work, then I give them some adrenaline. If the adrenaline works, great. Then I know that we're dealing with anaphylaxis or sepsis or distributed shock. Does that make sense? So I would treat and use my treatments to sort of help me guide my diagnosis. You're in a very controlled, safe, secure environment, and you're not going to cause them to arrest by giving them 1 milligram of aramine.
Yeah.
But what you might do is actually use it as an investigation almost to help you direct your treatment and to help you give you a diagnosis. Does that make sense? So
yeah, absolutely.
It is a bit of a trial and error thing. And anaphylaxis is often not obvious. So I'm glad you brought it up. And obviously you've done some anesthetics, so you've been taught about anaphylaxis and it's in the forefront of your mind. But anaphylaxis is not that obvious. And so if the aramine doesn't work and you can't get the blood pressure up, then go for adrenaline. What dose of adrenaline would you give if you think they're anaphylactic?
If I've got IV access, I'd give 100 micrograms. If I don't have IV access, I'd give 500 intramuscularly. I've probably got IV access. Pardon?
Yeah, but what do you think is better, actually?
What do I think? An adrenaline
Which one do you think
infusion.
is better? Yeah, so an adrenaline infusion is the optimal. So generally, what I do is I usually give them 500 mics of IM adrenaline. The reason I give IM is because it gives you a depot of adrenaline in the body. So you're not constantly having to give them mics of adrenaline.
That's
right?
clever, yeah.
So I give them 500 mics of IM adrenaline, and I've bought myself a couple of minutes. And I get someone to go make up adrenaline infusion. And I keep giving them IM until the infusion's ready. The problem with 100 mics of IV adrenaline, which you can give, very, very valid way of going about it, it dissipates so quickly. You are not going to be able to leave that drip alone, because every minute, 2 minutes, you're going to have to give them another 100 mics of adrenaline.
Yeah.
So that's the problem with giving the IV adrenaline. It's a very valid way of doing it. It's just I would do it slightly differently. That's how I do it.
Can I ask you, so, and I guess this is more just so that, like, this is a pretty common situation that I've seen happen in theatre, and nobody goes running to press the emergency buzzer when this happens. Like, it's pretty common, unless it starts to deteriorate from there. Is that been your experience as well?
Yeah, for sure. It's a fair question, but that's a question it's on the basis of experience. So the reason that most people aren't going to run to the buzzer is because if you're alone in theatre, you've probably seen enough of this that you know there's a few things you can try that are easily fixable and reversible before you know you're stuck. Does that make sense? So that is not to say that if you feel uncomfortable, that someone's blood pressure has gone from 150 to 75 systolic in a matter of 10 seconds, that you should press the buzzer. You should always press the buzzer. You should never hesitate to press the buzzer. However, the reason most people wouldn't run is because most of us know that there's a few reversible things that can happen. Like you said, that hypotension could just be induction drugs. That hypotension could be a bit of sepsis. That hypotension could just be that they've been fasting for 2 days because their case was cancelled yesterday. So because there's plenty of reversible causes that can come up that I can immediately treat, that's why I and possibly other people you've seen wouldn't run for the buzzer at that point. But by all means, if you don't have that experience or exposure, or you're uncomfortable, go hit the buzzer.
Yeah.
Does that answer your question?
I get so scared if I'm ever left alone. I'm like, I will be hitting the buzzer so quick.
And that's the right attitude. That's the right thing to do. Is as soon as you feel uncomfortable, you should hit the buzzer. Because the worst thing in the world is that if you're scared to hit the buzzer because you're scared of embarrassing yourself, and you chew up 5 minutes of time, 5 minutes with someone that's hypotensive is like 20 minutes of resuscitation. Because it takes a lot longer to bring back up someone's blood pressure than it takes to lose it.
Yeah.
So don't ever feel embarrassed about it. Just hit it.
Thank you.
But that's how I would go about it. Yeah.
Yeah.
I think it was a great scenario, actually, because it's a very common one. This one was complicated. So I think I saw Wendell. I saw Wendell in the chat. Wendell, are you here?
Unfortunately, yes.
I told you it would come around, my friend. All right, Wendell, this one's all yours.
Oh, okay. So a 55-year-old gentleman with a past medical history of hypothyroidism, hypertension, and a previous NSTEMI, LAD stent 3 years ago, no further complications, has a ruptured appendix and urgently needs an operation at 9 p.m. At the time of operation, he's febrile 38.3 degrees, CRP of 250, white cell count of 32, newts 18. Halfway through the OPS, he develops new rapid AF, but that's not been previously noted to a rate of 155. What would you do to manage this? Then after you've managed his arrhythmia, his BP drops from baseline of 145 over 100 to 80 over 50. persistently, mean arterial pressure of 48, what would your targets be and how would you manage?
Can I give you a bit of advice before you start?
Yeah.
Break this up as almost 2 scenarios. So
Yeah,
deal
I
with the
get
atrial fibrillation by itself first, and then talk to me about the blood pressure drop.
Yeah, so I guess the first thing, like let's say we're still like midway through the operation. This gentleman's now developed a rapid AF. So I guess a couple of things running through your mind. Just want to make sure that this he's not going to arrest, I guess, on the table. So you just run through your vitals again and make sure that hemodynamically you are happy with what's going on. So from the stem, it's implied that he's still maintaining his blood pressure with this rapid AF. But so A and B are already secured because he's in the operation, being tubed presumably, and is being monitored on the ventilator. So I guess my first concern would be, is he maintaining his hemodynamic state? So yeah, and to do that, I'd just be looking at his blood pressure, which is fine for now. And then I could be looking at ways where we could potentially, we could be looking at causes of this rapid AF that could have just developed, and what we could do to manage that in the meantime. So I guess one of the things we could look that could be causing the AF could be like his like the infection which has brought him into theatre in the first place. I guess other things that could also kick him into AF in this scenario could be if he's developed like not really sure, like a P or something like that.
Yeah, no, I think you're doing a great job, but remember, you have to treat. We have to decide whether to treat and diagnose at the same time. So I agree. Your answer is actually perfect if you're on the ward and the gen med consultant is asking you what caused this guy's AF. I think you're absolutely fair enough. And even in anesthetics, if you have the time to think about all those things, you do. But the first thing you have to decide is this a problem or not? And you're not necessarily going to have the choice of going through all the possible diagnoses before you make that decision. So what do you think? Do you think this needs to be treated or not?
I say if he's hemodynamically stable and let's say he's already anticoagulated, I'm not sure this is the most like this is not something that will kill him acutely, I guess. But like it will be something I'd be looking into, like I'd want to look further into and then try and optimize in like the short term, but not necessarily immediately.
That's absolutely fair enough. And I think this question for me signifies the difference between sort of ICU and anesthetics. In ICU, if I saw a heart rate of 155 with someone who was otherwise maintaining their blood pressure and was stable, I would treat the underlying cause, and I would go through exactly what Wendell just talked about. So I would go through the causes and treat the underlying cause, because the one thing you should remember is you should never just treat someone's heart rate without learning the underlying cause, because you might give them a beta blocker to slow them down, but if you don't fix the PE, can it go back up to 150 when that beta blocker gets metabolized out? So always treat the underlying cause. That's in ICU. I would leave it, I would sit on it, and I would see what happens, and I'd try and treat the underlying cause. In anesthetics, I think it's a little bit different, because you are pretty much in a physical state of trauma. You've got an open abdomen or an open joint, or in a highly stimulating environment where a heart rate of 155 is not conducive, because it's not going to stay 155. If the surgeon suddenly pumps some gas into your tummy to take your appendix out, that might go up, that might go down. If you're suddenly in a lot of pain because the orthopedic surgeon just hammered the shit out of your knee, that could go up. So that's why in theatre, it's probably slightly different. You need the patient to be more optimized. So running at a rate of 155 during a case where you're providing an anesthetic is not really a great option, because that will cause you instability. So you can choose to answer this question in either way, but because you're currently in an operation, answering from an anesthetics perspective, the first thing you should do here would be to put the pads on, because that will be your get out of jail free card. If this patient does go into an arrest, or even if you need to DCR this patient out of the AF, then you should put the pads on, because that's the safest thing to do for the patient. Because what you don't want is the patient to go into VT or VF and then run around trying to get a defibrillator in the room. So as soon as you see this happening, pads on. Yeah. Second thing is, how do you slow it down? Now, what medications, Wendell, do you know that will slow down this guy's heart rate?
Okay. I guess there are a couple of options we could look at potentially. So I think like we could consider something like metoprolol acutely to drop the heart rate down. Yeah.
Yeah, perfect. Yeah, beta blockers. metoprolol is a common one. In anesthetics, they tend to use ethnolol because it's shorter acting and quicker onset. But yes, beta block is a good answer. Great answer. What next?
Just trying to think.
It's okay, take your time.
I'm kind of pulling blanks here, sorry, man.
That's all right. No, that's fine. So the other thing you can use is amiodarone. So you'll often find patients in ICU on amiodarone, but you can definitely use it in anesthetics as well. So oftentimes you'll find people give a 300 milligram sort of loading dose of amiodarone, which they usually give over sort of half an hour. And generally that does an excellent job of slowing your heart rate back down to a manageable time. And then you can run an ongoing amiodarone infusion. And the other thing you can use is IV digoxin as well. So IV digoxin is also great for rate control in these cases. Now, all that is still just to buy you time to figure out why the patient's in rapid AF, but this guy's septic. So you know why he's in rapid AF, and you're currently in the process of fixing it. So your job is just to slow his heart down to get through the case safely. The diagnosis has already been handed to you. All right. And what do you do about his blood pressure? And what do you reckon a good MAP target is, Wendell?
Yeah, before I answer that, I was just thinking, I just had a thought. I was considering amiodarone, but given his history of hypothyroidism, I was wondering if that's like something would routinely give in this situation.
Yeah. What's going to kill him first?
Yeah, I guess his heart rate. Yeah, it's going to kill him first. And
again, excellent thought. Probably for a physician ward or for a gen med ward or for when you've got longer term medication, when you've got medium to long term medication, that is exactly something to think about. But in an acute setting, the question I always ask myself is, what's going to kill him first? And in this case, it's going to be a heart rate to an arrest. So whatever the other consequences, that's what I'd focus on first. Yeah.
Okay. Yeah, understood. And I guess like a second thing. So I guess the first thing we could try and do, like after we've already managed the arrhythmia, his BP is dropping. So to address the first part of the question, I think we'd aim for like a MAP over 65. If possible.
Yeah.
So that's enough. I think that would be a reasonable amount to maintain perfusion to the vital organs. So currently this is not good enough. So what we could try and do is give him like a fluid challenge, maybe 250 to 500 mils of fluid, and see how that responds. And then what we could do is if that's still not working and with the arrhythmia that's still present, then we could consider like other like inotropic support or like vasotropic support. So I guess like in this scenario, like the shock would most like the kind of shock that's sticking out to me is this could be like distributed due to like the sepsis. But like once again, if he was only maintaining his blood pressure with a heart rate of 155, like this, I could also consider maybe like a cardiogenic cause of shock as well, potentially.
Yeah, for sure. I think it's a perfect answer. And what inotrope do you think you'd reach for first?
Sorry. So I guess some of the options I could be reaching for first would be I guess metaraminol would be one option, and potentially even like noradrenaline if we think it's getting pretty bad. Yeah.
So great answer. I think you did an excellent job, Wendell. So I would go for the metaraminol simply because I'm lazy and it's in a pre-drawn syringe and pre-made, and I can give boluses of it. Noradrenaline you'd have to make up as an infusion and start it, and like I said, you need proper access for it, so you need a central line or bigger access, whereas metaraminol is just easy to give. It's already pre-drawn up in a syringe for you, and you can just hand bolus it as you need to effect. So but yeah, I think realistically you can use either if you want, but I think in practicality you probably tend to use aramine. But that was a great answer. I'm very impressed. Cool. Now this one's probably a bit more trickier. I think there's only two or three left. We probably don't have time to go through all three. We'll do this one and then the last one. Is anyone going to volunteer, or I'm just going to go through my usual game of just saying random names? Random names it is. CJ, are you here? Nope. Mike? All good. Maybe we give Matt another crack. Actually, Matt, do you want to have a crack at this one?
Sure. I'm just getting into the car.
Yeah, that's right. Sorry, Hannah, did you have something to say? Sorry, you just popped up there.
I was just going to say, I think Matt is going to work. So
Yeah, I'm just rushing out the door. Can I maybe pick
Matt.
someone else? I'm really sorry. I'm just
That's
maybe.
right. No.
I can
Sorry.
have a crack again if you want.
Thank you.
I don't know.
Oh
this
no,
one.
Hannah, I'll give you the harder one. Let's give this one to Rachel.
Okay, no, so yeah.
Oh, sorry, Tom's jumping in as well. But everyone's volunteering now. Okay, Tom, go for it.
I mean, I've already had a go, so if you're down for a repeat, I'll give it a go.
All right, maybe we'll give Rachel a go, and then we'll come back to you,
Yeah.
shall we?
Yeah.
Go on, Rach, go.
Hi, sorry for like a little bit of work. So I might have
That's all right.
missed some of the
Don't
useful
apologise to
tips
me.
at the start.
That's all right.
So you get called to see a patient in PACU post a routine knee arthroscopy. He's otherwise a well 30-year-old male who has now gone to SVT with a rate of 150 to 160. What would you do?
Super common. Happens all the time. You guys can do it by committee. If anyone else wants to help Rachel out, they're welcome to. If you want to leave her out to dry, you're welcome to do that as well.
What I start with, I mean, would you just start with just like vagal maneuvers, I guess?
Sure. What vagal maneuvers do you know?
Blowing into a syringe.
Yeah, blowing into syringe. What else?
I think there was one where you like, can't remember, like you lift their legs and drop their head at the same time or something.
Yeah, it's almost like a Trendelenburg. Yeah. You can do a carotid sinus massage. It's a really weird thing to do. You just basically go and press really hard into their carotid. Do one side at a time so you don't block off both of them at the same time, but that can sometimes help as well.
Right.
Cool.
I read, is that less, I was just, I understood, is that less preferred than kind of the other maneuvers because of like risk of
oh yeah, no,
embolism
it's
as well or
terrible.
something?
Yeah, you do the other things you said first, but that is something else you can do if the other things don't work.
Yep. Okay. And then if those don't work,
I can also help.
Yeah, go for it, Tom. Help her out.
It's adenosine. I think it's 600 mics. You can repeat that up to.
Sorry, I can't hear you too well. You
Hello,
might have to.
hello. Can you hear me?
Yeah,
Anybody
go
else?
for it now. Yeah.
Adenosine, 600 mics.
Yeah, that's one thing you can do. Adenosine is certainly something you can do. There's one other medication you can use before adenosine, but what else can you do? And adenosine is slightly different as well. So it's not 600 mics, it's 6 milligrams. So it's 6 milligrams, 12 milligrams, 12 milligrams is how you use adenosine. 600 mics is atropine is what you're thinking of.
Yeah, sorry.
No? Cool. So you can use adenosine. Sorry?
Amiodarone.
Amiodarone, great. We'll slow him down. What else can you do? So the answer is actually nothing. So you've got to think about the context in which this patient's in recovery. And this is something you will get asked to do a lot. As an anesthetic reg, as a medical intern, as a medical registrar, whatever you choose to do, you'll get to see this a lot. And your question is, you have to ask yourself, what do I need to do about the situation? If a young, fit, otherwise well 30-year-old guy is tachycardic, there's a million reasons it could be, and you've got time. If he's otherwise stable, you've got time to try and figure out those things. So you should try and figure out those things. Oftentimes you'll find that these settle on their own with a bit of fluid and some TLC. But if the fluid doesn't work, then you can do what you guys were talking about. You can try the adenosine, you can try the amiodarone. Be a bit careful with adenosine because adenosine is normally used to actually figure out an underlying rhythm. It can revert people in SVT, but it's a terribly hard drug to give because you need to give it very, very quickly and it makes the patient feel terrible. Your last port of call in patients like this where they have irreversible and sort of recalcitrant SVT is you have to DC cardiovert them. But simple thing, simple. So first figure out if you need to treat it, give them fluid, give them analgesia, because what if there's in a sinus attack because they're in terrible pain because of their knee? So if you've got time to think about other things, think about the other things first. So you don't always have to rush to the most severe and most important thing. And oftentimes you won't even need to get there. So if you've got a young fit guy, you've got time to play with, so play with the time. Yeah. If his blood pressure is low, completely different story. You need to take a different approach. If a blood pressure is low in someone who's got an SVT, your medications aren't going to work. You need to cardiovert the patient. So you need to get pads on, and you need to DCR them. All right. But that's a talk for a whole other day. All right. Any questions, Hannah? Or Rachel, sorry. Cool. Why wouldn't meds work? It's a good question, Daniel. It's not a question of the meds wouldn't work. So adenosine, do you know how adenosine works? I'll let him type it out, but yeah, perfect. But for how long? Briefly, exactly right. So basically, if you give adenosine, what you're doing is you're slowing down the heart rate enough to see what the underlying rhythm is. But it's not definitive treatment. In some cases, it basically acts as like a chemical cardioversion, but it doesn't actually cardiovert anything. Because if there's an underlying recalcitrant pathway, then giving the adenosine will just stop it briefly. And then as soon as the adenosine wears off, they're going to go back into SVT. So it can work. It's 50-50. There's no reason not to try it, but just remember simple things are simple. So if you don't need to run to the meds, don't run to the meds. But if someone is hypotensive, you don't want to risk a therapy that might not work. And even if you're going to do it, I would suggest that you do it with pads on. So if you're worried that they're hypotensive, you chuck the pads on, and then you can try your adenosine if you'd like, because if it doesn't work, then you know you have to shock them. But oftentimes when patients like this become hypotensive, you don't have a lot of time. They become hypotensive because he's a fit well guy. He's probably held on, his physiology is probably held on for a lot longer period of time before it's fallen off a cliff. And so you have less time when they deteriorate, but potatoes and potatoes, you can definitely try adenosine if you like. Does that answer your question, Daniel? Cool, no worries. How much longer do we have, guys? We can chill out here or we can keep going.
It's up to you. Maybe if it's a quick one, maybe one more, but otherwise, yeah, it's just gone after 7:30.
Okay, cool. Maybe we'll do the last one, and it's the hardest one.
Oh no.
Who's brave? Who wants to do ICU? Someone said they wanted to do ICU. Who was that for?
Was that me?
I think it was. Sorry?
Was that me in the pre-chat?
Yeah, I think it was.
Oh God, I haven't done ICU yet. Okay.
That's all right. It's tough, Anthea. Good luck. Take your time.
Okay. So a patient with known heart failure presents to you on the ward. She's in APO and currently unstable with a blood pressure of 80/60 with stats in the low 80s. First question, what next? How would you improve both her APO?
Oh, I wrote this in a hurry. What next, comma, how would you improve that, both her APO and her saturation?
Okay, should I answer that one first and then we can go on to the second one?
Yep.
Okay.
Yep.
Alrighty. So I guess this is always the I don't know, the dichotomy between someone being overloaded and hypovolemic, which makes it very difficult to treat, I guess, with fluids alone. All right, in terms of the APO first, she's fluid overloaded. So we can get fluid off, we can give some furosemide. In terms of the saturations, I would tend to I would be inclined to give it at least high flow because he provides some PEEP plus minus perhaps NIV. As that will
that was a rookie mistake, Anthea. How much PEEP does high flow provide?
Not very much though. Not very much.
How much do you reckon? Have a stab. How much do you think?
About 5 maybe, less than 5?
Not less.
Oh really?
Guess again.
1.
Yep. About 1.
Okay.
If that.
All right.
One if you block off both sides of their nose.
Oh, okay. Well, then that wouldn't be too helpful. So maybe we can tend towards NIV,
Sure.
as that would like decrease the preload and decrease, I guess, venous return. I guess.
So what do you think putting her on NIV would do there?
It might increase the intrathoracic pressure though.
Yeah, so it would drop her blood pressure because you'll catapult down your preload, and you'll increase your afterload as well.
Yeah.
So you're just going to make it really, really hard for her to breathe and to keep her blood pressure up. Sorry, to clarify, you will increase your right ventricular preload, but not necessarily your left ventricular preload because of the APO, but you will definitely, by putting her on positive pressure ventilation, increase her afterload.
Yeah.
Just to clarify. Yeah.
Okay. So is there much evidence then to put, I don't know, patients with APO on CPAP then?
Yeah, tons. They're great. That's the best thing to do to treat them.
Okay.
So what do you do?
And then I guess in terms of managing the blood pressure, then you would have to start also vasopressor, because we can't give more fluids to this patient. We're just going to increase their fluid overload.
Yeah.
So you can start something either like noradrenaline to cause increased vasoconstriction and increase their total peripheral resistance and increase their MAP, aiming a MAP above 60 at least.
Excellent. Now, this is obviously, I preface by saying it's a very complicated situation. So I'm going to help you out, but also poke holes in what you're saying. You will need to eventually start some inotropes. You've got no choice. Yeah. If you start metaraminol, aramine, or noradrenaline, you increase their total peripheral resistance, as you said. So what will happen to their right atrial return? What will happen to the amount of fluid going to their right heart?
Would reduce.
No, it would increase because you're squeezing it back, right?
Oh yeah, sorry, it would increase, sorry.
It increased, yeah. So if it's increased, it's just sitting there. What is it gonna do to your APO? You're pumping more fluid into your heart that's not getting pumped around the rest of your body. So it's gonna worsen your APO.
Yeah.
So be careful with inotropes in patients with APO because you might have a counteractive effect of making their APO worse. All right, cool. What else can you do?
Not too sure. Can I phone a friend?
So, yeah, anyone else want to help out? Anyone have any suggestions or ideas?
Oh, beta blockers maybe? If you want to decrease.
What do beta blockers also do? Yeah, so beta blockers will be terrible.
Yeah, that would do. Yeah, no, that's fine. No,
maybe very counterproductive to your situation. Look, this is a very common but incredibly tricky situation. So I'll answer part one for you, and I'll leave part two for you. I'll answer part one, and you can answer part two. All right. So this is a question of, and I'll say this again, is what's going to kill her first? It's always ABCs, right? So airway is really important. So you said non-invasive, and I think non-invasive is the right call for airway because the APO is what's going to kill her first. She's in acute respiratory distress and her lungs are failing. So it doesn't matter what her blood pressure is if she can't breathe and you can't oxygenate. The purpose of blood is to get oxygen around your body. So if there's no oxygen to get around your body, then it doesn't matter. What are you going to do with the blood pressure? So airway, breathing. So non-invasive for the airway and SATs at 100 for breathing, FI2 at 100 for breathing. All right. That will deal with your APO. What that will do and what you need to be aware of is your intervention at part A and B is going to make your dealing with part C a lot more difficult. So you need to then counteract what you expect to happen, which is an even lower blood pressure by treating with inotropes. So in this situation, it's a classic example of the kitchen sink approach. You have to do everything, and you have to do it all at the same time. So you have to do your A, you have to do your B, but you also have to start the inotropes at C very quickly because you need to give her the blood pressure so that even if you do oxygenate her, you need the oxygen circling around the body. There is no point in oxygenated blood sitting in your lungs and in your heart. So what I would do in this specific case, until I could get her safe, and because I know she has a shitty heart to begin with, is I would use adrenaline. Because adrenaline is going to have the multiple effects of squeezing her heart more, vasoconstricting her peripherally, and sending the blood back, but also helping my heart squeeze the blood further, and also increasing the rate that my heart's going to squeeze it. So hopefully increase my cardiac output in both ways and try and pump this fluid out of my lungs. While you're doing that, you can also start your other pharmacologicals. So you can start GTN to try and help with her with her APO. But remember, GTN is a vasodilator as well. But it's okay because you've got the adrenaline on board and you can go up and down on it. Does that make sense?
Yeah.
And so
yeah.
It's a matter of thinking about all the things you have to do all at the same time. And it's hard. Obviously, it's very hard. That's why I put this one last. But that's what you sort of want to focus on. And you will need inotropes, because the key here is you need the inotropes. And for an inotropic talk, that's why I'm getting to it, is that you cannot get away without inotropes in someone like her. Inevitably, she'll need it. And as a temporary solution, starting peripheral adrenaline when you have nothing else to go on is probably going to be her best chance of survival, especially because you know she's got heart failure. Does that make sense?
Yeah.
Cool. Any questions?
No, it's yeah, no, that made all sense. You just have to sort of go through each issue and do it all at the same time.
Yeah, and you know, obviously it sounds easy for us because you know I do this all the time and I do it every day. But you guys, the more you do it, the better you get at it. Cool. Now, part 2, go for it.
Oh, so once she's stabilized, you find that she's still hypotensive in spite of APO resolving. She has terrible peripheral edema, and you have told her INR is elevated and has terrible LFTs. So I think from this, she's developing some sort of right-sided heart failure that is now that's backflowing and I guess causing hepatic congestion, and that explains why I guess her liver synthetic function and LFTs have gone off. Yeah, what do it is that?
So my question is, what inotrope would you use here?
Well, let me think.
Actually, a better question is, what inotrope would you add? Let's assume that she's still on the adrenaline.
Millerone, maybe?
Yeah, Millerone, perfect, exactly that. So this is the only situation that you will find people using the inodilator class of inotropes. So the dobutamine and milrinone is in these patients, the patients that have right heart failure. And while they're on adrenaline, so something to squeeze their vessels, or noradrenaline, something to squeeze their vessels, they need your heart to be able to take in more of a load. So people with right heart failure, because it's not as contractile as your left heart, so you'll need to use more, basically you need to give it more fluid to pump as opposed to trying to pump it harder, because there's not enough muscle tissue in your right heart to just increase the pump. So the only way to increase the pump of your right heart is to give it more fluid and hope that it works. So that's when you use your dobutamine and milrinone. Whereas if you've got left heart failure, adrenaline is going to help you. So in this particular lady, what she's actually got is biventricular failure. So she's got left heart and right heart failure. So the left heart failure, you're helping with the adrenaline, and the right heart failure, you're going to have to try and help with dobutamine or milrinone. And that is how you would classify her inotropic situation. Does that make sense?
Yep, that makes sense, yeah.
Perfect. The adrenaline also has the added effect of peripherally vasoconstricting it, which will also help when you inodilate her as well. Cool. And just some last couple of things. For people who are going to end up doing an ICU rotation soon, vasopressin is used in mostly into sort of severe sepsis when patients are already on really high doses of noradrenaline or adrenaline. It is very, very, very late line therapy. And generally when people are on like 20 or 30 of NORAD is when you'd consider it. And the reason is because it's so potent and causes terrible, terrible peripheral ischemia. I've seen people lose hands, fingers, and toes because of being on vasopressin for weeks. So it's a terrible drug. It's only used in severe sepsis, because it's not going to help you in cardiogenic shock because it doesn't do anything to your heart. All it really does is terribly vasoconstrict you and try and increase your blood pressure. Steroids in inotropic use, we tend to use steroids when people have been on inotropes for quite a period of time, but it's basically to upregulate your postsynaptic receptors. What happens is after you have been on inotropes for a week or two, you find that your inotropes become less efficacious because all of the postsynaptic receptors are saturated. And so to upregulate how many of those receptors are available for binding to NORAD, you use steroids. There's still a lot of research being done on it. It's still pretty routinely done in ICU, and there is some mortality benefit to doing it. So that's the other thing. Terlipressin and octreotide we talked about briefly. very specific use. It's in patients with esophageal varices, who you think are having an esophageal bleed, and that's just because they're both very specific to portal venous vasoconstriction. And lastly, switching inotropes and methods of administration. So inotropes are any inotrope can be given peripherally. The only ones that are safe to give peripherally for a prolonged period of time are aramine and ephedrine. And that's just because they're not directly acting inotropes, they're secondary inotropes, whereas everything else, as soon as feasibly possible, should be given centrally. So in other words, with a PICC line or a central line. And that about covers it. Does anyone have any questions? Sorry, I went a bit long. No, all good.
If no one has, oh, sorry.
Yeah, I'm happy to leave my details with the organizers. If any of you guys have any questions or want to reach out to me at some other point, by all means, just send me a message or send me an email. I'm happy to help. But otherwise, sorry, hang on. Daniel did have a question. How do we know the increased afterload won't cause the APO to get worse due to reduced cardiac output with adrenaline? I think I might have answered that when I was explaining it, but you don't. It's an excellent point, and you don't know that the adrenaline will not, but you've got no other choice. So you're going to have to just bet that your increased cardiac contractility, your peripheral vasoconstriction, is going to overcome that increase in afterload. Cool. Sorry, go on, Rachel.
If no one else has any kind of burning questions they want to ask, I will probably wrap it up then. But I just wanted to say thanks, Sachin, for speaking. That was I think it's really good that we got to go through those cases at the end. It's just always good to put like the knowledge into practice and like apply the knowledge. And yeah, and thank you to the audience for coming, and thank you for participating in the cases. And a reminder that we're doing a raffle. Yep. PVACCS is one of our sponsors, and we're giving away 12-month access to the 𝗲𝘀𝗀𝗀𝘀 stations database. So feel free to fill in the form. And recording of this event will be put up on our YouTube channel as always. The link is in the chat. And that will close off our crash course series. So this is our last event for this kind of segment of events, and keep a lookout for our next events, which we have currently in progress, probably workshops. I believe will probably be up next. Vascular access. So keep a lookout on that for those. Thanks, everyone.
Thanks, everyone.